Okay, so let's go ahead and get started. This is Paul LabID here at CDC in Atlanta. You know me from your day-to-day interactions with us through the NHSN CDA box. And for this month's vendor meeting for NHSN CDA, we're going to talk with Barry Rhodes and Arun Srinivasan, who are two of our informatics folks here on the NHSN side. We're going to talk a little bit about some of the future directions we're taking, electronic reporting and CDA. Again, for those of you who are just joining, ask that you mute your lines, and we'll actually do that on our end as well. And we'll take questions at the end of our slides. We don't have a ton of slides. There should be ample time for discussion. So with that, I'm going to turn it over to Barry Rhodes.
The conference is now in silent mode.
Okay, good afternoon, everyone. This is Barry. What I wanted to do today was to spend some time talking about some of the different projects we have going on within our branch to help and assist you in electronic reporting. Some of the ideas are more others, some in pilot mode, some are actually being used, some are more conceptual. And our interest here is really about making electronic reporting easier. We understand it's hard. I monitor the CDA inbox. I see some of the pain that you're feeling. Certainly, we've heard a lot about some of the issues that you have with changes and so forth. We're trying to make this as possible we can. These are some of the ideas that we've come up with. Some of the ideas are from feedback from you. Some of them are our own ideas. But we really want to push this forward. There are currently around 1,000 facilities that report at least one event type using clinical document architecture messages. And while that's a fairly impressive number in the grand scheme of things, we really want to move that forward. And in order to do that, we need to make this as easy as we possibly can. So that's what we're going to talk about. Some of these will address some of the shortcomings of NHSN, our move to electronic messages. Others are simply ideas. In the end, we need your feedback because really this is all about assisting you, making your lives a bit easier so that we can receive electronic data. So as you're hearing about these various initiatives, feel free to jot down notes. We'd love to hear this is a great idea, but could you do it this way? Or, could you really do something like this? Keeping in mind, of course, that we have to support everyone and that we want to be as standards-based as we possibly can. So I'm going to talk about several different initiatives, and let's just go ahead and get right into them. So the first initiative we can talk about are some web services that we've produced, and these are actually in a sort of limited beta right now. But I wanted to talk about them a little bit because I think they could be important moving forward. We've taken the protocol for ventilator-associated VADS, and as some of you are probably aware, we created a calculator which sits on the NHSN website, the cdc.gov/NHSN website. And we've gotten a lot of good feedback from the calculator, but it's really a JavaScript calculator that runs in a client browser. People can enter data, but it's not really reported anywhere. But it does implement the VAE protocol. What we wanted to do was extend that one step to allow vendor systems to create batch files that they could submit in a batch mode to a web service. The web service would then take the data, run through it, apply the algorithm, and return results. And it would do that without receiving any personally identifiable information. And this is a work, it's, as I said, it's a pilot. It's very much a work in progress, but we do have a website where you can actually see and play with this. It's the second bullet down, nhsn.phiresearchlab.org. This is the Innovations Lab at CDC. It's cordoned off from the rest of the CDC. We can't use real data with it per se, but we can open it up to the public. So you can go to that site. You can see the web service. There's a web page that calls the web service. I'm assuming most of you are familiar with web services and how that works. Or you could call it directly from some sort of scripting language or from within another app or else. But there is a web page that allows you to call the web service and see both what the input and the outputs might look like. There's also some information on it. It's in need of updating, so it may not be 100% accurate. But you can see the web service in action. If you're interested in actually piloting that, just drop us an email and let us know. We'll work with you in order to validate that, see how it might work, and to really get some feedback on it. We imagine that eventually it will be cloud-based, again, because this idea that we're not requiring personally identifiable information. So we're thinking it might be a real good candidate for a FedRAMP implementation on the Amazon cloud. It doesn't store any data. There's no data procedure. And what it could do, which is the exciting part to me, is that when you submit these data sets, it could return all the positives back as clinical document architecture messages, skeletonized, if you will, so that there would be no names, no personal identifiers, but you could simply fill in the blanks in the CDA. Then you would have something that you could report securely. So it's really a two-step process that we envision that we're trying out. So feel free to take a look at that. We're working on both on this, which is fairly mature at this point, and we're in the process of coding something for MDRO LabID events as well. We've chosen those two as our first candidates because those two lend themselves most readily to electronic data. Most of the data for MDRO LabID events as well as VAE could exist electronically and oftentimes do exist, though not always, within an electronic health record system or some sort of health information system in a hospital. So that's pretty much web services. And again, love to talk to you if you'd like to take a shot at trying that out. This is an example data set. It's in XML, so you can sort of see what the input is. There's a couple things to note. Each patient is identified by a sequential index. The reason we do that, again, is to ensure that you're not putting in names inadvertently or even local IDs. So there's a little more work on your end to do this, but the payoff is that we can keep this service completely open. It's not password protected. Eventually, it will be over secure socket layers or TLS. But it can literally be an open web service, and we feel like that's gonna help tremendously. So you have to keep a record. The calling program needs to keep a record of patients and map them to a sequential index. Days are the same thing. So instead of giving us dates, as in September 1st, you're giving us day 1, day 2, day 3, and the explanations for how those days are counted are on the website. So again, this really reduces the amount of identifiable information to pretty much nil. You don't know really where the data is coming from. You don't know what the patient local ID is. You don't even know the dates that you're submitting. Again, you would keep that all behind the scenes. Once you receive the results, you'd get a result for patient 4 that has a VAE on on day 6, and you would map that day 6 back to a specific date and that patient 4 back to a specific patient. You would then take that information, aggregate it, put it into a CDA, and then you'd report it securely through the typical channels. So another idea, and this is really in just sort of a concept phase, but we want to hear your feedback on, is this concept of a vendor portal. I know that a lot of the information about NHSN is spread over different pages, and the whole structure of the website is really geared towards infection preventionist users, if you will, of NHSN, and not necessarily vendors, and certainly not necessarily people who are creating CDA. So we're thinking that we could create a vendor portal which would be specific for vendors or healthcare institutions that were creating clinical document architectures directly to go to find all the information that you know about direct, about the implementation guides, about vocabularies, about virtually everything you would need to know, sort of a one-stop shop, if you will, to learn about electronic reporting. So this is still, like I said, a concept, but we want to hear your thoughts about it, what should be included, what shouldn't, how should it work, how interactive should it be, and so forth. So if you have thoughts about that, please let us know. Here's an idea we sort of stole from ONC, from their certification program. We are not in any shape, form, or fashion going to certify systems. But what we can do is look at some of the certification process and see where it might be of use to us. So one of the ideas, and again, this is an idea that actually Arun is looking into, is to, I'm sorry, this is a pre-production test instance. So this is another idea that came from suggestions from you. And we are in the build-out phase of this. It's not available yet, but we expect it to be in the next few months. And this is an instance of NHSN. Again, it will be at the same URL as the website, as the web services will be, that will allow you to test your CDA instances against a pre-production test instance. So this is prior to us going. One of the things we've heard is that you don't have enough time to test, and so this is our attempt to get you as soon as we possibly can actual code that you can test your CDA instances against. There's some restrictions on this, of course. This again would be all test data. There can be no live real data submitted to the test instance, and even at that, we would purge all of the data, the patient data, every evening. You could, hopefully, at some point, will be connected through direct, so you could use the direct protocol to send to the test instance, get a test error report back, and sort of learn the whole system that way. The information about facilities, all of the user information would persist. That would not be purged every night. So you could set up a test facility or multiple test facilities if you wanted. You would have your users there and so forth. So all that would persist over time, but anything that you submitted, even if it were test data, gets purged every night, just to make sure that nobody inadvertently sends us real data and we end up with real patient records in our test data set. But we're working on that as we speak. Again, this is ultimately to go out on onto FedRAMP, again, because the security requirements are pretty low for this. But right now it'll be in our research lab. More to come on this when it does become available. We'll probably send out a blast email to the vendor list, letting you know that it is available. And then again, we need feedback on this. There's a lot of questions that we have about how to best do this. We have no idea what level of usage it's going to take. It's going to be hard to resource. Initially, we need to figure out all of these things. How are you going to test? Are you going to have automated scripts against it? There's all sorts of questions that we don't have answers to yet. But we decided to go ahead and put it out there, start to beta test it with you, get feedback from you, because we always think it's better to have something to sort of talk against or work against. And then to get your feedback on how best to do this and to move forward. So again, look for a blast email when this is available. We'll probably start small. I don't know that direct will be initially connected to the test instance, so you'll probably, the first iteration of this will allow you to manually upload your CDAs and test them that way one at a time. But we ultimately imagine that, this will be a full-fledged test instance of NHSN prior to production. And when I say prior to production, I think all of you realize that we're in a sort of twice-a-year cycle of releases. So what that would mean, and most of the major changes to our data occur in January, but there are changes that occur mid-year as well. So, we're talking, probably 3 months prior to our release where this might be available. And again, it just sort of depends on our development cycle and where these changes are going to occur. We certainly want to do them as quickly as we could within the development cycle, but that doesn't always work out, as I'm sure you're all aware. So as soon as we can get something out to you, we would. And that would be prior to production, but I can't promise exactly when. And again, we need to sort of work through those questions with you. Also, how long does the test instance stay up as we move forward? So other questions to talk about as well. So all these things will sort of be revealed as we move forward and as we beta test this. So this is what I started to talk about earlier. So one of our ideas, and again, this was stolen from ONC certification, but again, we're not in the business of, and we don't expect to get in the business of certifying vendor systems. But one of the things we thought about we could do, and we realized that certain vendor systems code our definitions, our algorithms, if you will, within your products. And we've never really done any sort of validation on that. I mean, I'm sure you've coded them well. I'm sure that's, but we've never really, worked with you to do that. So here's yet another way to go about doing this. We have been discussing amongst ourselves an effort to put together an EHR data set, electronic health record data set, that would be seeded with events. In this case, maybe ventilator-associated events, maybe LabIDs, maybe others as well, and that we could distribute that data set to you. It would allow you to then take that data set, import it into your own systems in however way you'd want to do that, and then run your own algorithms against it and compare your results to the known results for that particular data set, which we would publish on the website as well. And it would be a way for us to, and you, to sort of validate that you're interpreting our code correctly and that the results of the data that you're sending to us are in fact have some validation. We would hope to include as many of the sort of edge cases as we possibly could within that data set to make sure that we're catching all those. But that's the idea. And again, this is in discussion right now. We'd love to get your feedback. Some of our ideas was, one idea on the table was to actually create CCD documents that would have each patient record embedded in it that we could provide to vendors to import directly into their products. Or if we didn't want to go that way, we could create or make available flat files or XML formatted data. But we need to sort of know, what that data might look like, what would be the easiest thing for you to import, and how that would work. So we're looking for partners on that. Arun is really going to spearhead this initiative. And we'd love to hear your comments and thoughts about how useful that would be to you. Because again, this is our idea. We thought it might be useful, but we really need to hear your input on that. Okay, I think the next slide.
The conference is now in talk mode.
I'm going to turn this over to Arun because Arun Srinivasan is our other informaticist here in our branch, and he's been working on this problem. I'm going to let him sort of introduce it and tell you a little bit about his efforts. So, Arun, if you could take it away, that'd be great.
Thanks, Barry. Just want to check, can you hear me, Bill?
Yes.
Okay, thank you. So, yeah, this started as an activity that in our division to understand the distribution and the use of the IDM. We started to review some of the feedback that you as users have been providing us over a period of time. I know Mindy and Paul have been receiving quite a number of information from you on some of the challenges that you face whenever there's an update to an IDM, whenever new information is available. Knowledge that the use of the Excel as a medium to distribute this complex set of information, we call it the IDM, is far from being optimal. So, I mean, really the limitation of Excel platform has introduced a number of challenges over the period of years, particularly lack of context in the way information is presented. And time and again, we have seen versioning has been a big issue, particularly trying to figure out, what is the delta between releases, things that you need to go back and update in your system. Trying to get that information out of this Excel platform has been quite difficult. The other common theme that we find is documentation has been sparse on during the IDM release. You had to maintain different versions of it, and then I know Mindy and Paul have been so many times to kind of provide you on the IDM content. Has been a pretty challenging activity. So to address these challenges, we are in the phase of conceptualizing what would be a potential solution for this. And so one of the things that we have learned from some of the industry practices, and here's where we would expect you to provide us a feedback on this, is to expose the IDM content in newer usable formats, and we are thinking both in human and machine readable formats. So particularly we are envisioning to have independent repositories for these different elements within the IDM. For example, the vocabulary is probably residing in a standard repository like a PHIN VADS, which has been the Public Health Information Network's vocabulary distribution system, or even when VSAC, the enter from NLM, when it's available for real-time use, probably we can either host it through that or through the CDC PHIN VADS system, and probably even the business rules are integral part of the IDM can even be stored in a machine processable with associated documentation for both these business rules, and hosted in a rules repository and probably access them electronically as well. So the value of having them in separate repositories is we can have a better versioning system that kind of takes away some of the current challenges in maintaining both for internally within our NHSN system development as well as for you as vendors when you want to make updates and changes, trying to figure out deltas from each releases. It will be much easier to handle. So that's kind of the vision that why of breaking this instead of having this one monolithic Excel application, Excel platform, a file that we send around, rather have them as more structured representation of the information itself. We envision probably having a web portal that Barry was talking earlier, probably have an extension to that kind of a web portal and have the ability for you to dynamically query these different repositories and even have the ability to package data from these different repositories and load it into your system in different formats as applicable for you. So that's kind of the grander vision now. What we'd definitely like to hear from you is your thoughts on how we can make this process and see if this is something that would fit within other domain that we just, as a first step, what we have started to work is we started looking at PHIN VADS and VSAC as products for our vocabulary management and value set management, and we are currently evaluating these two products. When it comes to the business rules, we are really faced with the tough question of what's the value proposition for using something like a Drools-like platform to manage these business rules, and would it be valuable to you as users to have these in Drools, or maybe like simpler representations, maybe even some use flowcharts or something at that level would be much easier to manage these business rules, or would it be valuable to have Drools or in syntax? I know each industry partner has been using different technologies. Drools seems to be one of those framework that meets the use case well, but what we would like to understand is what would be the value for you as users if you had to go with that route. So if there are other technologies or machine processable formats that you think are appropriate for LabID. So that's kind of the main focus of area for this future of IDM. We'd definitely like to hear more feedback on this particular domain. Barry, back to you.
Great. Thanks, Arun. Yeah, the IDM, I know, has been a pain point for both you and us. NHSN started many years ago at this point and was fairly small, and Excel spreadsheets seemed to work just fine for managing this. We have way outgrown that. But deciding, what the best technology is and what the best system is for managing our vocabularies and our rule sets is still something we're working on. So, again, your feedback would be invaluable to us as we move forward with this. But it is as painful to deal with internally as I'm sure it is for you externally. And so we are looking to move forward with something that works a lot better. So a couple things about the future. We are expanding our informatics and resources in general for electronic messaging. We hope to have that in place by midsummer. Not that Mindy and Paul haven't been doing a wonderful job, but they're sort of overwhelmed at the moment. And so we're going to have more resources to help us out here. And that's going to make things go easier on this end. Certainly we can provide more assistance to you as well. And as we did last year, NHSN is working on, with EPIC, to set up a vendor meeting. Many of you attended last year's APIC meeting in Fort Lauderdale. How could I have forgotten? And what we did last year, for those of you who weren't here, is we had a room off the main meeting site where we had a large meeting, several hours of vendors who came, and we gave presentations, and then we did one-on-ones with vendors that requested it, and we're more than happy and, in fact, eager to do that again. So as this becomes a bit closer to June, we'll probably send out another blast email to let you know. You will need to sign up with us so that we can schedule a time with you to meet one-on-one. We, I think, scheduled 2 hours last year, and it wasn't enough. So, we're really committed to being there and working with you and sitting down, and we'll have our IT staff, our technical folks there as well, so that we can work out issues if necessary, and really get down into the weeds if necessary. We'd love to hear your suggestions at a higher level as well there. So we will hopefully be at APIC this year, and look for another blast email. And finally, I sort of wanted to give you a little bit of the big picture here, because as I mentioned at the beginning, we have over 1,000 facilities reporting CDA, and for a public health system, honestly, that's pretty amazing. But it doesn't come close to the totality of the data that we're getting, and we have a keen interest in moving away from manual data entry for any number of reasons. The burden it puts on hospital staff, the inconsistencies associated with it, any number of reasons.
The conference is now in silent mode.
So we recognize that in order to really move forward with electronic data, many of our definitions are going to have to change. The definitions were created in a time really almost pre-electronic at this point, and they really rely on human data interpretation and clinical judgments. And I'm thinking a lot about surgical site infections, central line associated bloodstream infections, and some of the definitions and procedures associated with those. And we understand that those don't lend themselves to electronic reporting or the use of existing data, I should say. They can be reported electronically, but I also understand that you are receiving them via forms that mimic NHSN in many instances. And so we understand that that has to evolve in order to really move electronic reporting forward. So we are working on a national conference to really bring together thought leaders across the board. These would be folks from public health, vendors as yourselves, academia, folks from CDC, to all come together with a concerted effort to reach some consensus on a national strategy for translating some of these things into measurable, computable definitions that we can begin to implement electronically. And that's the longer picture for us. But it has to go through that step, and that's not going to be an easy step. A lot of science has to occur in order to transition those definitions to things that are meaningful and to understand the associations and relationships between what might be new definitions and the current ones. So it's not going to be easy, but we recognize that that's what's really going to have to be done. And again, look forward to announcements about such a meeting. We're still looking for resources to support that. But we've gotten a lot of positive feedback from people we've presented it to, so we think it's going to happen within maybe a year and a half at best. So with that, that pretty much concludes what I had. So as always, we appreciate your patience in working with us, and we look forward to the day that all NHSN reporting is electronic. Thank you very much. We'll open it up now for questions or comments.
The conference is now in talk mode.
So anyone have any questions?
Barry, this is Sarah. You mentioned that you wanted feedback on several of the things. Do you want us to just send you an email with the feedback? What are you looking for?
Email would be great. The NHSN CDA mailbox would work just fine. It goes directly to me and the whole team, so we see it. That would be a good place. Or a direct email would be fine as well.
Yeah, and we'll send the slides out for you guys to have those to be able to look at around the same time that we get the recording posted. That's usually a pretty quick turnaround. My Montana's had some staffing issues recently, but we'll have the direct webinar that we did last month posted as well as this one. So you'll have the slides and the recording if you want to review it when you're thinking of feedback.
And we will, of course, keep those confidential. All right, well, hearing no comments or questions, again, thank you for your time. Thank you for your patience in working with us, and we look forward to working with you in the future.
Bye, everybody.
The leader has disconnected. This call will now end.